Okay. Good evening, everyone. Thank you, Georgie sir, for this opportunity and for creating this wonderful platform for sharing knowledge. And thank you, Dr. Vilesh, for the nice introduction. Without wasting time, let me go to the topic proper. The topic is on optimizing hypertension management using ABPM. Now, the time has changed. The ABPM is now very freely, easily available, and it is not very costly affair. So I think we should be always optimizing or fine-tuning our hypertension management so as to prevent all the complications of the hypertension. So, BP measurement is one of the clinical procedure we always do, but I will say this is something which we all do in a slow-paced manner. And how should we measure the BP properly? There are certain set of guidelines which all need to be followed, like no caffeine, exercise, or smoking for the last 30 minutes, seated quietly for a chair for 5 minutes, feet on floor, arms supported at heart level, cuff bladder encircle at least 80% of arm circumference, at least take 2 measurements and take an average, inflate 20 to 30 millimeters of mercury above pulse extension and deflate at the rate of 2 millimeters per second. And onset of the first Korokov sound will be taken as the systolic BP, and disappearance of the Korokov sound will be taken as a diastolic BP. But just do a self-assessment. How many of us follow these guidelines? How many of us measure BP properly? How many of the nursing staff or our juniors do take the BP properly? And we are always or most often managing patients with inappropriately recorded blood pressure. The implications are very high. Even the literature review system analysis found that 70 to 90% of the doctors and nurses do not follow these guidelines based on the different studies available in the literature. The implications are very clear, because if you underestimate the BP by 5 millimeters of mercury, 2/3 of the hypertensive patients will be missed. And if you overestimate by 5 millimeters of mercury, more than double the number of patients will be wrongly diagnosed as hypertensive. So, and that is regarding how we measure the BP. Most of the time, errors and mistakes can happen. We do not stick on with the guidelines. And even if you do the BP measurement properly based on all the above set guidelines, still there are a lot of fallacies for the office BP. Office BP, I mean the clinic BP. So white coat hypertension. Any patient coming to the clinic, seeing the doctors or nurses, obviously BP goes high. And it is very common, at least in 10 to 20% of the patients, and sometimes it will be more. And it will be falsely labeled many patients to have hypertension, and will be unnecessarily starting medications for these patients. If you want to detect white coat hypertension, there are two ways. Either we should have an ambulatory BP measurement, 24-hour BP, or ask the patients to record BP at home using a reliable BP monitor. So that is white coat hypertension. And as Dr. Vilesh already told, there is another thing called a masked hypertension. Patient is actually hypertensive, but because of the high BP variability, sometimes when patients come to the clinic, their BP will not go high. And we'll be falsely labeling the patient as a normal BP, but actually they are hypertensive. And this should be specifically suspected when they have an endocrine damage. Even this masked hypertension will go unaddressed if you do not do an ambulatory blood pressure monitoring or a home BP monitoring. So ABPM, if we apply ABPM for any patient, the fallacy of the wrong BP measurement, which I already told, we have to stick on with the guidelines, will not be happening. We'll get a correct BP measurement of the 24 hours, and it can pick up the white coat hypertension and masked hypertension. So that are the two advantages of ABPM. And I will start with a scenario. So I like this to be a case-based discussion. So we have a 46-year-old male, no addictions, no comorbidities. Patients come to my OPD. First visit, BP is 150/90 millimeters of mercury. Again comes next visit. I told, so BP is just a borderline high. You don't need to start a medicines. Let me monitor it more. Second time he comes to me, BP is 146/90. Third time he comes to me, BP is 146/88 millimeters of mercury. Obviously, the BP values are above the cutoff. So anything above 140/90 millimeters of mercury is hypertension. So what should be the next plan of care? I'll just give the 4 options. Either I should start on a lifestyle management, or should I start on a lifestyle management plus single antihypertensive, or should I do a home BP monitoring, or should I apply ABPM? That's my question. Everyone can just have this question in your mind. I will just discuss it. So what should be the next management? all the 3 times in the office, in the clinic, the BP is high, but it is not very high. And if the BP is very high, like like 180 or 190 millimeters of mercury, obviously that person is very grossly hypertensive. We have to start on medicine. But this BP range, like above 140 to 150 range, it could be because of the white coat hypertension, or it could be patient is actually hypertensive. We cannot differentiate it. If it is a white coat hypertension, starting on a treatment is inappropriate. The patient may go into hypertensive episodes when he is at home. So we need to differentiate what exactly is the cause for this borderline hypertension. It's not actually borderline, it's a bit hypertensive. What exactly? These three office BP or clinic BP, I will just put it in the waste basket. I cannot take this office BP as reliable to start on medicines or to make any diagnosis or to anything. So what should I do? So first principle while you're diagnosing a patient as a hypertensive is make sure that the patient is actually hypertensive before you proceed with the treatment. You should not proceed with the treatment with all these types of borderline hypertension without confirming it. It could be a white coat hypertension. Already discussed, we have two ways, either a home BP monitoring or a ABPM. So which one is easy? Home BP monitoring and digital BP monitors like Omron. Omron is a validated machine. I'm very big fan of the Omron. It's cheaply available, less than 2,000 rupees. So they can monitor the BP at home. And another way is applying an ABPM. So which is easy? Obviously, home BP monitoring is easy, but ABPM has got its own advantages. So I always motivate the patient for an ABPM. And obviously, I also motivated this 46-year-old gentleman for an ABPM, and ABPM was initiated. And what I found was the 24-hour mean BP was 126 bar 82 millimeters of mercury. It is only 126 bar 82. So what is the diagnosis? All the 3 times when the patient came to the office, came to the clinic, the BP was high, but the 24 hours mean is not that high. So this is an definite case of white coat hypertension. But is white coat hypertension that a benign thing? So the literature, the evidence tells that even if it is a white coat hypertension, it is associated with the increased risk of cardiovascular events and all-cause mortality. So always, even if I diagnose this patient to have white coat hypertension, but I should always keep a watch on this patient, should have a regular follow-up. Sometimes in near future, the patient may actually become hypertensive, and these patients are at increased risk of cardiovascular events. So here I found that 24-hour mean BP is not high, but that is not over. So this analysis or interpretation of the ABPM is not over by just a 24 hours mean BP measurement, mean BP interpretation. We have to split the BP into two halves, the mean daytime BP and mean nighttime BP. You can see the mean daytime BP is 122 bar 80 millimeters of mercury, and mean nighttime BP is 130 bar 85 millimeters of mercury. So this is a catch. So what should be? The nighttime BP should be normally low than in the daytime BP. So there should be a 10% dip in the nocturnal BP. So this is physiological. If this 10% nocturnal dip is not there, it is defined as a non-dipping. This non-dipping, even if the 24 hours BP is normal, this non-dipping, that is a reduction in the blood pressure during sleep by 10%, if it is not there, it is an independent risk of CV mortality, irrespective of the 24-hour BP. So that is one of the great importance of ABPM. If you do not do ABPM, there is no way we can understand how the nocturnal BP is. The nocturnal BP is one of the most important part of the BP measurement. And if you just see the circadian rhythm of the BP gradually comes down with the sleep, and the lowest BP is attained at around 3 a.m. After 3 a.m., BP gradually starts to rise, and peak BP we are obtained at around 10 a.m. in the morning. So this is the normal nocturnal BP fall followed by the BP surge. And why this BP falls during the sleep? It is because of the decreased sympathetic activity that corresponds to the stages of non-rapid eye movement sleep. And also, this BP fall corresponds to the cortisol secretion. This cortisol increases the sensitivity of the blood pressure to norepinephrine. So if there is less cortisol, there will be less sensitivity of blood vessels to norepinephrine, and the BP falls. So this two has got a this two moves correspondingly, this cortisol secretion and the BP fall. And here we found that the nighttime BP is actually more than the daytime BP. So this patient is not having the normal physiological nocturnal dip. In fact, this patient is having nocturnal hypertension. So this is an independent risk for cardiovascular events and cardiovascular mortality. So this patient, even if it is a white coat hypertension, this is not a benign thing. This patient is having nocturnal hypertension, is a non-dipper, he is at risk. So we have to explore more into it. And Ohasama is an area in Japan where a lot of research and studies were done on ABPM. And what was the study? So 1,542 residents in Ohasama, Japan, aged 40 years, above, followed for survival for 9.2 years. And with ABPM, each 5% decrease in the decline in the nocturnal systolic or diastolic blood pressure was associated with approximately 20% greater risk of cardiovascular mortality. This is irrespective of the average BP. This is holds true even if the 24 hours BP is the normal range. So all of us need a nocturnal BP dip. If the nocturnal BP dip is not there, it is an independent risk factor for cardiovascular mortality. And also, I already diagnosed this patient to have a white coat hypertension. White coat hypertension and non-dipping BP is always have some association. Maybe because of this association, this patient is having a non-dipping. And the things are not over. I found that this patient's average BP is normal, but the nocturnal dipping is not there. This patient is having nocturnal hypertension. So we need to know what more we can do for this patient. Should this patient receive some treatment? And what more we have to explore for this patient. And I took the history in depth, and what I realized is that this patient is having a significant snoring at sleep, and sometimes a daytime sleepiness. And sometimes the daytime sleepiness is very severe. And even waiting outside the OPD, this patient sleeps. So there is a high possibility for obstructive sleep apnea. Obstructive sleep apnea is one cause for the nocturnal hypertension, isolated nocturnal hypertension. And I did a level 3 home sleep study. And what I found that apnea hypoxia index was 28. Each hour of sleep, 28 times the patient goes to apnea or hypopnea. So this is the reason why the nocturnal BP is high. So treating the obstructive sleep apnea can control the nocturnal hypertension, and we can recreate the nocturnal dipping. And the discussion about the nocturnal non-dipping is not over if I do not touch about the chronotherapy. Many of the times we will get, if you do an ABPM, we will get patients whose nocturnal BP is not dipping or they are having nocturnal hypertension. I always advocate chronotherapy for this patient. What is chronotherapy? That is coordinating the medical treatment with a patient's circadian rhythm to maximize the treatment and effectiveness. Like we want to artificially create the nocturnal BP dip. So we want to create the nocturnal BP dip by adding medicines at night. And those medicines we are going to administer at night should be short acting. So there is a one important trial called Heart Outcome Prevention Evaluation, HOP study in 2000. Ramipril administration at night decreased this cardiovascular risk by controlling the nighttime BP. And it was associated with 22% reduction in the cardiovascular death, myocardial infarction, stroke, despite only modest reduction in the BP. So this Ramipril is actually AC inhibitors, which is not a very long-acting agent. Duration of action is only 12 to 14 hours, and the peak action will get at around 4 to 6 hours. So adding AC inhibitors at night can artificially recreate the nocturnal BP dip if the patient do not have a dip in the ABPM. And also, ifidipine retard, which also has got a peak BP lowering action at 2 to 4 hours, or a clonidine or a labetalol, all short-acting agents having a BP reduction, maximum BP lowering at around 4 hours can be used to artificially recreate the nocturnal BP dip. So this chronotherapy can be used if you find that your patient is not having nocturnal dipping of the blood pressure. And one point I always emphasize is if the patient is on a single antihypertensive, always place it at night, not at the daytime. It is that during the sleep, normally physiologically, you want the lowest BP. So if the patient is started on a single antihypertensive, please start that antihypertensive at night, not at the morning. And always there is a general tendency among many doctors and physicians to start the antihypertensive in the morning. Maybe morning time, we start an antihypertensive, patient will be very happy. So they will find that the blood pressure in the normal range during the daytime. The nighttime BP is never checked. We are not doing ABPM routinely. So that should not be the case. We want the best BP control during the night. Most of the cardiovascular, even strokes, MI, pulmonary edema do happens in early morning time. So please place the single antihypertensive at the night time. And if the patient is on a multiple antihypertensive, always place maximum antihypertensives at the night time. So this is one trial, one study where the treatment with more than one antihypertensive at medication at bedtime compared with all antihypertensives during the daytime. So the more antihypertensives at night time significantly reduce the cardiovascular morbidity and mortality significantly. So if the patient is on like four antihypertensive, let 3 antihypertensives be at the night time, only 1 at the daytime. And you can streamline this if you do an ABPM. And for certain antihypertensive, certain group of medicines, it is a best practice to avoid morning dose. For example, in the beta blockers, atenolol, and regarding AC inhibitors and also regarding ARBs, losartan. These group of medicines do not have 24 hours duration of action. If you're starting it, either start in a BID dose, morning and night. Or if you're only planning to start at the once daily dose, please place these medicines which do not have 24 hours action at night time so that the nighttime BP will be better controlled. So placing these antihypertensives during the morning, actually they found that it increases the cardiovascular risk. And regarding the BP dipping, the discussion is not over if I do not mention about the extreme dipping. Extreme dipping means the BP fall during sleep more than 20%. It is very rare, but sometimes you can see, most commonly in the elderly. This extreme dipping is an independent risk for the cognitive impairment because during the sleep, because of extreme BP dipping, the perfusion to the brain is affected, can affect the cognitive decline. And if you find an extreme dipping in the ABPM, do not place multiple antihypertensives at night time, more antihypertensives in the daytime. But this is not very common. So you should not be very worried about this extreme dipping. But keep in mind that there is an entity called extreme dipping. And another important point we should look into while we interpret ABPM is the BP variability. Our blood pressures are always variable. Minute to second, minute to minute, hour to hour, and day to day variability is there. So in ABPM, we'll get a 24-hour blood pressure variability. High blood pressure variability is not very good. It is an independent risk, regardless of the absolute BP. It is an independent risk of target organ damage to heart, liver, kidney, arteries, brain, everything. And multiple studies has demonstrated that high 24-hour BP variability is an independent risk. So we want to have a smooth BP. We don't want to have a high variable BP. And one measure by which we can document the 24-hour BP variability is in the ABPM. With every BP, we can have a mean BP and its standard deviation. You take the standard deviation divided by mean blood pressure into 100. So that is a coefficient of variance. The CV, coefficient of variance in blood pressure variability. If CV is more than 10%, that means this patient is having high BP variability. We have to reduce the BP variability. And for the medicines, the CCB is the best medication which can reduce the blood pressure variability. There are beta blockers and all, in fact, sometimes increases the BP variability. So if you find that the blood pressure variability is very high, keep in mind, irrespective of the 24 hours average BP and absolute BP measurement, it is an independent risk factor for cardiovascular events. Make the BP more smooth by applying or starting a calcium channel blocker. Amlodipine is the best. Cilnidipine or any calcium channel blocker can be used. And I already told I'm discussing about ABPM. I'm just comparing the office BP, that is our clinic BP, with 24 hours ABPM in predicting the cardiovascular morbidity and mortality. And most of the studies has found that the absolute CV mortality better correlates with the ambulatory blood pressure monitoring, ambulatory BP, than a office BP. And regarding the stroke risk and subclinical cerebrovascular risk also, for the stroke also, this office BP is not a risk factor. But the nighttime ambulatory BP is something which predict the cognitive decline and subclinical strokes. So for the brain also, what the most important thing is the nocturnal BP, which can be only obtained if we apply a ABPM. And regarding nephrology, elevated blood pressure in ABPM correlates more strongly with the progression of to ESRD than clinic systolic blood pressure. And the nighttime ambulatory BP, nighttime BP is a more stronger predictor of death and ESRD for CKD patients. So for CKD patients also, if we apply an ABPM and tailor the treatment based on the ABPM report, we can retard the progression and can prevent death from CV events. And before the last part of this session, I need to put up a question. What is the normal blood pressure? So normal blood pressure, there is a lot of discussions happening over the years. The normal blood pressure, the categories and the guidelines and definitions keep on changing. And for the final consensus, we can take any blood pressure above 140 systolic and 90 diastolic, we can take it as a high blood pressure. And less than 120 and less than 80 should be taken as normal. But is this a broad one-size-fit-all definition for normal blood pressure and hypertension is applicable for all? No, one size do not fit all. So normal BP depends on age, sex, ethnicity, genetics, and lot of unknown factors. This type of just broad definitions and broad classifications are only useful for enrolling patients for clinical trials. It is not useful if you are practicing a precision medicine or a personalized medicine. I'm going to stitch a coat for all these three kids with one size. It is how it looks like. This is how if we apply this BP definition, hypertension guidelines broadly. So this is an era of personalized medicine or precision medicine. So we want to go more precise, more into the person, more into the. For example, this is the Yanomami tribes in the Brazil rainforest, Amazon rainforest of Brazil and Venezuela. And this group of tribes do not have any access to salt. For generations and generations, they do not eat salt. And their normal blood pressure is 96/60 millimeters of mercury. If someone comes to the hospital with this low BP, doctors and the emergency physicians may put up into the ICU and start noradrenaline. So, but this low BP 96/60 is the normal blood pressure for this Yanomami tribes. Maybe because they are not exposed to sodium and they eat a lot of potassium in the form of berries and fruits. But what I need to emphasize is that there is nothing called a normal BP. Normal BP should be always personalized or individualized. And even for males and females, the BP is different. For age group also, the normal BP is different. So we need a precise or precisely diagnosed hypertension for all. For example, I have a 42-year-old male. His office BP and home BP is always between 130 to 140 and 80 to 90 millimeters of mercury. So based on the guidelines, this is not a hypertension. This is borderline. Is it a risky BP and should be treated? First of all, we don't know their baseline BP, like how his BP was years back. Sometimes years back, his BP was only 110/70. And so if the baseline BP is very low and over like 5 to 10 years, his BP increased to this level, in fact, this can produce end-organ damage. So if you want to be more precise or specific for these types of borderline BP, it is always better to apply an ABPM. If you apply an ABPM, we get a lot of additional information. We get a nocturnal BP. If for this patient, if you do not have a nocturnal, if this patient is having a non-dipping during the sleep, this borderline BP is risky. Please treat it. We may start on a chronotherapy, that is a treatment at night time. If the BP variability is very high also, this is an independent risk factor. Start on a very small dose of a CCB to maintain the BP, to reduce the BP variability. So applying ABPM for this type of borderline BP can make the treatment more precise. And based on the ABPM guidelines, you just have to memorize what is hypertension. So based on the ABPM, normal 24-hour BP should be less than 125/75. Nighttime BP should be less than 110/65. Daytime BP should be less than 130/80. And home BP, so this is the cutoff for the ABPM. So any 24 hours BP more than 130/80 is taken as hypertension for ABPM, and nighttime BP more than 120/74 ABPM is taken as nocturnal hypertension, and daytime BP more than 135/85 is taken as daytime hypertension. That is a cutoff for ABPM. But we should not stick on with this absolute value. We should look at the nocturnal BP fault, the percentage, and blood pressure variability. And a few additional informations we can obtain from ABPM is the syncope evaluation. If the patient is having recurrent syncope or free syncope, and if you're suspecting the postal hypertension or BP fluctuation, ABPM pick up it very well. And it is very useful to pick up episodic hypertension like in pheochromocytoma. And we also get the heart rate. So if the heart rate is high, we can decide on the beta blockers. And 2 slides on the technical aspect. If you're using an ABPM, ensure that you're using the device that is having international standards, ensure adequate cuff size, and ABPM should be done in a normal working day rather than a rest day to obtain the typical blood pressure profile. And we have to obtain a log of activities, wake and sleep time, medications, meals, and occurrence of symptoms. And when the blood pressure cuff is inflating, keep the arm rest so that we will get the measurement properly. Readings will be taken 15 to 30 minutes during daytime. We can set it, and 30 to 60 minutes at night time. And 85% of successful reading, we can analyze the report. And regarding the complication of ABPM, because of the multiple inflations, sometimes small petechiae can happen under the cuff. And for a few, they can have a sleep disturbance, something tied to their arm. It can disturb the sleep, and it can even rise the nocturnal BP. And the last scenario, we have a 56-year-old male, hypertension for 15 years, no diabetes, office BP, 3 recordings, average is 186/94 millimeters of mercury. Patient is on prazosin XL 5 milligram 2 times, amlodipine 10 milligram morning, and nebivolol 5 milligram 2 times. How should we proceed? I always do ABPM. I get a lot of consultation from the hospital for this type of uncontrolled hypertension. Please do an ABPM. But I'm tired telling everyone that don't apply ABPM for this very high BP. Please control the blood pressure to a reasonable extent by adjusting medication. I started on a telmisartan and chlorthalidone and spironolactone for this, and the blood pressure came down to 150/90 millimeters of mercury. Then apply ABPM so that we can fine tune the treatment. We can know how the BP is in the daytime, nighttime, during sleep and all. So don't start an ABPM and the BP is grossly high. Obviously, you will get a very high BP in the ABPM. Control the BP to a good extent and then fine tune it. Sometimes you will get an unanticipated hypertension or low BPs, or sometimes still we can find that the nocturnal BP is high. So for the fine tuning, we can use an ABP. And for the conclusion, 24 hours ABPM is the gold standard, I will say, because more accurate diagnosis, because it picks up white coat hypertension and pick up mask hypertension. And we'll get additional crucial information like nighttime BP, nocturnal dipping, and BP variability. So the question of the day, do ABPM have several advantages? Yes. Is doing ABPM easy? No. Someone has to go to the home, apply the ABPM, and it is cost around 2,000 to 3,000 rupees. So ABPM is costly. Is adopting ABPM in routine day-to-day practice good? I will say it is very good, because additional cost and effort from ABPM are counterbalanced by the cost savings due to complication prevention from better targeted treatment. And now almost all international guidelines and our national guidelines endorse ABPM. So that is all about ABPM I need to discuss for this 30 minutes. Thank you very much.